Wireless Motor capsule has been approved by US FDA. Once ingested, the wireless motor capsule measures pH, temperature, and pressure throughout the GI tract. The completion of gastric emptying is demonstrated by an abrupt change in pH into the alkaline range when the capsule passes into the duodenum. So that is how the change in pH helps us to diagnose gastric emptiness, difficult or not. Coming to differential diagnosis, very difficult to differentiate between functional dyspepsia and gastroenterologist here, we will be doing better. On the basis of the current definition, gastroparesis is basically indistinguishable from functional dyspepsia and gastric emptying. Pancreatic cancer sometimes may present in such a manner with a lot of GI symptoms, weight loss because of malnourishment is in both cases. And other differential diagnoses include chronic intestinal obstruction, rumination syndrome, adrenal insufficiency, hypothyroidism, dyslipidemia. These are easily can be identified and we can rule out basically the other causes can be ruled out patient presents with some symptoms. Management basically is not much elaborate. Most importantly, glycemic control, dietary changes, I will go into the next few slides. Pharmacotherapy based mainly on the prokinetics, which will help the food to go down. And in very refractory cases, there are some interventions which are done by surgeons and gastroenterologists. So glycemic management is a mainstay. A1C has to be under control. Most of the guidelines now recommend based on timing range, at least less than 180 is preferable in most hours of the day. Pharmacotherapy, there is some controversy. Most guidelines recommend that oral agents should not be used. This is because the PKPD of oral agents are impacted by the delayed gastric emptying. Biguanides can cause GI intolerance. Sulfonylurea has a risk of hypoglycemia. Alpha-glucosidase inhibitors may be beneficial but cause diarrhea and abdominal distension. GLP-1 RA pramlintine again delay gastric emptying and therefore they should be avoided preferably. However, the risk of removal of GLP-1 receptor agonist should be managed against their potential benefits. Some studies have shown the benefits of pioglitazone in the treatment of gastroparesis, effect on restoring the GI neuronal nitric oxide synthase, and impaired nitric oxide synthase pathway in the meningeal plexus and loss of neurons due to oxidative stress is assumed to contribute to gastroparetic symptoms, and pioglitazone may be beneficial in the treatment. Insulin still is the mainstay of therapy, especially in long-duration diabetes and type 2 diabetes. But in patients with gastroparesis, a mismatch between insulin action and glucose absorption can result in wide fluctuations in glucose, a lot of hypoglycemia and hyperglycemia have been noted. CSII, if possible, can be an effective option to maintain a good glycemic control, especially when the patient is having frequent hypoglycemia. Dietary modifications, very important. Small meals, less in fat and indigestible fibers. Patients in advanced cases are advised to consume more of liquids and easily digestible food, which can easily pass. This is something we have to really change in diet. Fat and fiber intake minimize, avoid carbonated liquids and multiple small meals. Coming to pharmacology, if you can see, it's very surprising to see that even now, after so many years of having so many prokinetics, metoclopramide is actually the only FDA-approved therapy for treatment of gastroparesis. Other than that, we have domperidone and erythromycin. Metoclopramide can be used in the dose of 5 to 10 mg, DT or TDS. Problem is that we cannot use it more than 12 weeks because of adverse effects. The patient can develop extracurricular side effects, hypercholesterolemia. Domperidone advantages is that it does not cross the blood-brain barrier, less likely to cause extracurricular side effects. Erythromycin again is off-label treatment, 250 to 500 mg thrice daily. Again, developed tachyphylaxis cannot be used beyond 1 month. Etoposide has been used, again is not FDA approved, but it is still being used quite a lot nowadays. Advantages of etoposide, again, less side effects. Dual mechanism of action, blocks D2 receptors in the esophagus stomach, reduce dopamine control of GI motility and improves GI motility. It also causes acetylcholinesterase inhibition. Concentration of acetylcholine is increased in synapse, and this also improves the GI motility. Now, antiemetics, phenothiazines, antihistamines have been tried, but there are no RCTs to prove their efficacy. We have some newer drugs like ghrelin receptor agonist relavoreline, which stimulates gastric body and enteral contractions, excellent with gastric emptying, currently in phase 3 trials. Prucalopride can be used in some functional constipation. Again, it has been investigated and there are some beneficial results which have been seen in treatment of diabetic gastroparesis. Basically, it is a 5-HT4 agonist. Now, there are some studies and we have meta-analysis of relavoreline, more than 1,000 patients, quite satisfactory efficacy. Key adverse effects include sudden episodes of hyperglycemia, and this may be due to accelerated gastric emptying resulting in quicker nutrient absorption. There are meta-analysis of trials on 5-HT4 agonist, 5-HT4 receptor agonist, particularly Velucetrad drug, felicitrin drug. They have also shown remarkable benefits in the treatment of gastroparesis, reduction in symptoms, and overall side effect profiles are quite acceptable. Among emerging therapies, tradipitant is one drug which is under clinical trial. It is an antagonist of tachycardia receptor 1. Mechanism of action is inhibition of substance P from binding to NK1R, reduces symptoms of nausea, vomiting associated with these disorders. A lot of other drugs which have been studied, rifaximin, buspirone, but not much clinical benefit which still is there to be approved by FDA for the treatment of gastroparesis. In refractory cases only, we have to move beyond pharmacotherapy intervention. There are studies where intrapyloric botulinum injection have been given. There are symptomatic improvements in some patients, but 2 double-blind studies again did not show a reduction in symptoms. Interventional therapy, pyloric intervention, pyloroplasty to widen the pylorus and prevent spasm, pyloromyotomy or gastric paroral endoscopic myotomy. These are procedures where incision in the wall of the pylorus where endoscopic intervention has been done to improve the symptoms, to improve the passage of food from the stomach into the pylorus. Gastric electrical stimulation is approved by FDA in drug-refractory diabetic gastroparesis. Basically, it is a gastric pacemaker, a device implanted into the abdominal wall which generates 12 pulses per minute, just takes over the intestinal cells of Magellan's function. The study reported an improvement in 75% in 151 patients that have been studied. And interventional therapy to improve nutrition, these are only in extreme cases when the patient is extremely malnourished, unable to take anything directly. Direct percutaneous endoscopic tracheostomy feeding tube may be inserted to improve feeding and nutrition. And finally, this is the last resort where if very seldomly done, gastrectomy is seldomly used as a last resort for diabetic gastroparesis. All symptoms are totally refractory to all sorts of treatment. To summarize, up to 50% of patients with diabetes have delayed gastric emptying, which can be documented by scintigraphy, 13-carbon 13 breath test, wireless multimeter capsule. Hypoglycemia, autonomic neuropathy, enteric neurovascular inflammation and injury are implicated in the pathogenesis. Initial options include dietary therapy, improvement in oral nutrition, prokinetic agents, and more severe symptoms with interventional therapy. Promising newer therapies include ghrelin receptor and agonists like remamorelin and selective 5-HT receptor agonists. With this, I end my presentation. I thank you all for your patient hearing.